Good morning, everyone. Welcome to the January 24th Informational Forum with Access Health Connecticut and the Department of Social Services. My name is State Representative Carrie Wood. I'm chair of the Insurance and Real Estate Committee along with Senator George Cabrera. We will pass it along for opening comments from the chairs. We're also here with the Human Services Committee. Senator Cabrera, any opening comments?
Good morning, Representative Wood. Good morning, everyone. Hope everyone's having a great day. I'm looking forward to this informational session and learning as much as we can in ways we can work together. So looking forward to it. Thank you.
Thanks, Senator. Senator Lesser, co-chair of Human Services.
Thank you, Madam Chair. And it's good to see you and to work together on this incredibly important, timely issue. I am of the opinion that redetermination, the loss of health insurance by potentially up to 400,000 Connecticut residents, by some estimations, that's over 10% of the state's population, is maybe the biggest single issue we have to wrestle with as policymakers this year, this spring in particular, and that's going to start in just over a month. And so making sure that we're working with Access Health and DSS to make sure that folks are redetermined successfully, that we don't see an unnecessary loss of coverage is going to be really, really critical. And speaking personally, I think the Human Services Committee is excited to partner with our friends over at the Insurance Committee and the stakeholders on the executive branch and the exchange to make sure that we're moving expeditiously and including all of the stakeholders, including hospitals and community health centers, community health workers, and other frontline providers to make sure that we're able to not let people fall through the gaps. Thank you, Madam Chair.
Thank you. Representative Gilchrist, any opening comments?
Great. Thank you so much, Madam Chair. And sorry, I was a few minutes late. Just thank you for organizing this today. I'll echo what my good senator said. This is a first for the state. And so I think it's important that we work as a team and support our state departments as we go through this process. So interested to learn today. Thank you.
Thank you. From the ranking member on the Insurance and Real Estate Committee, Representative Pavlak D'Amato.
Good morning. Good morning, and thank you everybody for coming, and thank you Representative Wood for having this. And I do always find these informational gatherings very, very helpful as we move forward in this session. So thank you again.
Senator Wong.
Thank you, Madam Chair, and welcome to the world of virtual connecting. I'm glad we're able to do this, and I'm very eager to hear where Access Health is moving forward after a couple of tumultuous years, and to have DSS present as well is a wonderful duo. I think there's eagerness among all of us to find out what is really happening and to engage in how we can provide critical services to the community. So thank you very much for coordinating this, and look forward to listening to the people.
Great. And to the ranking on Human Services, Representative Case. Is Senator Seminara on? Okay, we will move over to our speakers. Access Health Connecticut, I see you have a team on here. Feel free to take it away. And what we'll do is we will hear the presentation. And after that, we will open it up to questions.
Thank you, Madam Chair. This is James Michel. I'm the CEO of Access Health Connecticut, and we look forward to presenting to you our strategy. And I want to echo everyone who has spoken, and particularly Senator Lesser, who was very articulate in stating that our chief concern is making sure no one has any gap in coverage. After almost 3 years of about 430,000 Connecticut residents are part of the Medicaid extension as of March 31st, that we would have to go through over a 12-month period to redetermine the entire population of the 430,000. And those who do not requalify for Medicaid, we believe very strongly that they may qualify for QHP, and particularly cover Connecticut. Now, we have been planning for the unwinding of Medicaid extension for over 12 months now. We're again working collaboratively with DSS, so we have a very detailed approach, involving community outreach, and we've already updated our system in preparation for the end of Medicaid of the unwinding of Medicaid. However, the real challenge is going to be communication, and we have been working very, very closely with DSS, our marketing approach, as well as our community-based in-person outreach that we're going to do to minimize the risk of someone losing coverage. Now, what I would share with this group is that one of our primary concerns is that somebody who is chronically ill, who is on a maintenance drug to manage their chronic illness, not knowing that they've lost coverage until they go to refill their prescription, which may be a 90-day supply. That's when they first learn that they've lost their coverage. Then they call us. Then we jump to all types of hoops to make sure to restore their coverage, working with DSS. That happened. That used to happen on a regular basis, but over the last 3 or 4 years, we have not seen that because of the Medicaid extension. So we know what we have to do to make sure that no one, to minimize the gap of to minimize the risk of anyone having a gap in coverage, because we know this is about, in some cases, about their lives and the family members' lives. So we have a presentation to you where we're going to outline our strategy, detailed strategy, how we're going to communicate, how we're going to do our marketing, and also, more importantly, how we're going to be present in the communities to make sure those who are impacted have the access they need. With that said, Madam Chair, I would pass it on to DSS if they have an opening statement. After that, we could get into the slides.
Sounds great. Anyone from DSS would like to give an opening statement?
Yeah, I'm here. My name is Morgan Leary. I am a representative for DSS. I'm currently the workstream lead on our communications project, working very closely with Access Health. And I just want to second everything that James Michelle has stated. We're working very closely together with our community partners and Access Health, who has an amazing marketing team.
Good. Yeah. Good to see you. I'm trying to do a Zoom for our community.
Can all members please mute themselves?
You're okay. Good to see you later.
Justin, can you please mute everyone?
Okay. So looking forward to sharing all the hard work we've been doing and what we have to come in the future to make this unwinding process as seamless as possible and to prevent any gaps in coverage, especially to those with high-risk medical issues. Thank you.
Okay, I'll pass it back over to Access Health Connecticut. If you'd like to begin your presentation. You can
Sure.
take it from here.
Thank you very much, Madam Chair. Can we start the slides? And I'm not sure who has, okay, here we go. So Caroline, are you up first? Can we go on to the next slide, please? So this is,
I had a little trouble unmuting myself. My apologies.
no problem.
Again, my name is Caroline Lee Ruette, and I am the Director of Marketing here at Access Health Connecticut. We've worked closely with DSS to create a presentation for you today. As we understand it, there were 3 really hot topics that we wanted to cover off on. The first being Covered Connecticut. The second being exchange plans and new carriers, potential new carriers. The third being Medicaid extension unwinding. And then lastly, if there's time, we will go through a quick open enrollment update for this group. We are just completed with our 10th annual open enrollment, so we have some updates for you there. And then also, we did introduce the concept of the Broker Academy last year. And so we would like to give you a quick update too at the end if there is time, and of course, allow some time for Q&A. So we're going to start our presentation about Covered Connecticut, hearing from the folks at DSS who are managing this program.
Hi, my name is Jennifer Marsacci. Excuse me. I am the program manager for Covered Connecticut for DSS. I was asked to provide a high-level summary of the program to date, assuming that most on the call know about the program and what it's designed to do. So here we have a timeline of the Covered Connecticut program, beginning in 2010 with the Affordable Care Act and the cost sharing and APTC implementation and the state health insurance exchanges. Excuse me. In 2021, as folks are aware, ARPA and APTs were expanded, and Covered Connecticut program was approved by the General Assembly for a certain population. And then it was expanded in April of 2022 to include all non-pregnant adults ages 18 to 64 and unmarried. Actually, scratch that. It doesn't matter if they're married or not. And program year 2 began on July 1 of 2022. In December of 2022, excuse me, waiver application, which was submitted in May of 2022 with the approval of the Connecticut General Assembly, was approved. And we are in our first weeks of demonstration year 2. Demonstration year 1 was 2 weeks long, began on December 15th and ended on December 31st. Next slide, please. This right here, and I'm sure folks from Access will probably go over this in greater detail later in the slide, but this is the current enrollment in Covered Connecticut by carrier as of January 20th, 2023.
Thank you. And now we're going to move on. We have prepared a slide for you from Access Health's point of view, just to talk a little bit more about how we are working. We've said it several times now, really collaboratively with the Department of Social Services to get the word out. So we've done a variety of things throughout the course of this program's totality, but we're going to focus in on what we've done since phase 2, right? The launch of phase 2 started July 1st of last year. And what we did to kind of kick things off really is we did a press release. So focusing on the second section here, we launched phase 2 of the program in English and Spanish with a press release. And we really focused on the updated eligibility and new benefits, including dental and non-emergency medical transportation, making folks aware of the new eligibility criteria, as well as those new benefits. In addition, we sent out a vast swath of geo-targeted emails promoting enrollment fairs by zip code. So there's a lot going on in this particular bullet. Ultimately, our outreach team did a ton of enrollment fairs, making sure that folks had a place to go to get free in-person help. And in order to get bodies there, right, we were able to go into our system at a zip code level and really geo-target people that could have gone to those events because they live nearby. So really wanted to make everybody aware of everything, but also drive based on where people live to get them to the most appropriate place. We also did a lot of collaboration with different partners. Folks have reached out to us really wanting to get the word out. One example of that was Anthem and the Yukon Health Provider Networks. They asked us to work with them on some collateral for their patient networks that they pushed out. So really looking at, non-traditional marketing alternatives to get the word out as well. Of course, we created some collateral, updated one-pagers branded to support our outreach team, as well as the legislative network. If you don't have that, we're happy to get that over to you. And again, this is available in English and Spanish too. We've continued our social media coverage, doing some paid social media during open enrollment, and then organic social media continuously to raise the awareness about this program. We also took a look at our website to make sure that we were getting the word out appropriately for people. So we made some updated content on our homepage. We have a blog that's pinned to our homepage actually. So there's a feature piece of content and that links through to a really detailed Q&A page on our website. So tons of information available digitally, in person, in the news. And we also have some talking points and suggested social media posts, a lot of content in a digital toolkit for community partners and the legislature. We encourage you to look at this at accesshealthct.com/toolkit. We regularly update content here, so please be sure to check it out, and we'll make sure that you're alerted when we have updates to that as well. And then lastly, up at the top of the screen, I want to talk about a big effort that we did at the beginning of open enrollment this year. So we went and did a direct mail effort to 44,000 Connecticut residents. We followed that up with an email and an SMS campaign, which is text messaging. And the reason why we lead with direct mail, I just want to remind everyone that is the only piece of information that we require of our customers in order to enroll. We feel that if we require an email address or a phone number, a cell phone number, right, that could be a health disparity. If somebody doesn't have access to that type of technology, doesn't know how to use it, right, then they might not be able to engage with us. So you only require a physical mail address. So the best way for us to reach everybody is to send out a direct mail piece. And then if people have opted into email or text messaging, we follow up with those things. So we hit them a couple of times with messaging. So in terms of our targets for this campaign, we went in our data back 3 years. So a significant amount of time sending to anybody who would have qualified for the program, assuming all their personal information stayed the same. Now, we know a lot of things happened over the course of this pandemic, right? A lot of people got different jobs, moved around, et cetera. So a lot of household information would have changed. So we knew there was a lot of spill in this campaign, right? We were probably reaching people that weren't going to qualify anymore, but we wanted to cast a very wide net. And this was the best way for us to do that using our data. The current enrollment, this data is as of January 19th, so a couple of days ago. For Covered Connecticut was 15,460. And then really thinking about that direct to consumer, direct mail effort, what did it yield us, right? That's a question you might have. So ultimately, 1,629 unique users from about 1,300 households are now in the program. So I'll pause there. I'm not sure if there are any questions on this slide or the previous slides that were presented by the Department of Social Services, or we can move on and hold questions until the end, whatever is preferred here.
Maybe we should open it up to questions because there's a lot on this slide.
Yeah.
So yeah, thank you for offering that. I think that would be a really good time to open it up for questions. So I think what I'm interested in, and I'll just start, is, you know, what you talked a lot about content and like texting and mail. I mean, what's more effective, like putting tons of content out there in front of people, or more of that direct to consumer in-person signing up? I mean, I find it hard to believe that sending out texting and letters is actually, you know, enrolling people. But, you know, you share with me what's more effective.
Yeah, so I invite some of my other colleagues to jump in here. But ultimately, we can hold an event, but if nobody knows about it, we're not really going to get a lot of people there. So we like to host our own events and tell people about it. But our outreach team is really great about being at places that are unexpected too. So that could be fairs and festivals, things like that around the year. And our outreach team is heavily present at places like that where people just gather naturally to get the awareness factor out there as well. So it's really a combination of efforts, but once you start having that conversation or hosting an event, you need to have something to hand to people so that they can understand and digest, and then also know where and how to enroll. So it's a combination of traditional marketing as well as in-person outreach. And this is a point we make regularly, and I think we're the point that you're making too, Rep. Wood. In order to move this particular audience, you have to have some personal conversations, hand-to-hand combat, right? And so we need to do that. And that's really where a big area of our focus is. But this marketing just kind of supports those efforts.
But it sounds to me like your response is that hand-to-hand combat, that one-on-one, that personal interaction is the best way of getting people signed up, correct?
Yes, and we've hosted a variety of enrollment fairs. So I tried to speak to that a little bit in terms of, we email people to get them there, but we host a variety of fairs, and the events team goes to hundreds. Our outreach team goes to hundreds of events each year that aren't hosted by us. So we're there.
Representative Woods, James Michelle, I just want to reemphasize what Caroline is saying, that we know this population. We are putting everything on the table to reach them, but we know the most effective way to connect with them is through community-based organizations and also in-person events We know that many of them go to certain organizations for help and guidance for a number of areas in their lives. And so we know we have to partner with those organizations that also be present in the communities where those folks are, and we know where they are because they're in our system. We know where the zip code. We know where the most impacted zip codes are. Whether it be in Hartford, Bridgeport, New Haven, or London, but we know where those folks are. So we know we target our outreach efforts specifically where there's a dense population within that makes up that 430,000 folks who may qualify for Cover Connecticut. But I'm going to ask my colleague Tammy Hendricks, Director of Health Equity and Outreach, to talk more specifically about the type of in-person events that we host throughout the year. Tammy?
Right. Thank you, James. And thank you, Caroline. You've explained it very well. Marketing and outreach, we work hand in hand, but we have two separate departments. So Caroline is responsible for spreading the message to as many people as possible. And then we capture those people when we're in person doing our events, whether that's just sponsorship events, giving information. We do on-site enrollments, right? We're helping folks who don't understand the process and we're enrolling them on the spot. We also do trainings for over 1,800 community partners. We work with them on a daily basis. So the marketing and outreach, it really goes hand in hand, right? Marketing helps us capture the attention of a lot of people. And then we're in the communities actually explaining, giving information and training. So it definitely is a combined effort. Two separate departments though. So our focus is really concentrated on what we do. So outreach is on the ground, marketing is kind of in the air. It's the aerial view of everything. I hope that helps.
Yeah, I mean, I think that the concern that you're hearing from us is what is the most successful way that you guys have measured for signing people up so that they are not falling through the cracks? Like, what is the best way? Where do we get the best bang for the buck? And is that being measured? And are we, investing more in that process versus, I mean, there's so much happening on this slide. What is the best way, the best bang for our buck in getting people signed up?
So, Representative Woods, the in-person events, I've used the term hand-to-hand combat. You have to be in the communities in person. Last year, we expanded our outreach department by hiring 3 new employees, bilingual employees. We created a new department. So again, the importance of being in the community in person is the most effective way to get to reach this population. So we created a whole new department that just does that for us. So that's Tammy's department. It's about a year old, and their purpose is to be in the community on a regular basis to enroll, to inform, and to answer questions. That's the most impactful, effective way to reach this population, and that's why we created this new department. And so we know that's been effective because compared to last year, during the most current open enrollment, we've seen an increase in enrollment in our own program, the Access Health program, as well as the number of people that we are seeing year over year have also increased by over 30%. So we know this works. Then again, we hired 3 to 4 new employees since last year for this specific purpose. I hope that was helpful and provide some more clarity.
Yeah, I mean, in my few years here as Chair of the Insurance and Real Estate Committee, I have not seen a 30% increase in the amount of people covered under Access Health Connecticut, but I think we can probably get to that in a future slide. I have talked enough. I do want to pass it over to anyone else that has any questions. Senator Lesser.
Yes, thank you, Madam Chair. And I was a little taken aback by some of those recent comments. I mean, I think it is wonderful that you hired 3 to 4 new people last year to do outreach, and I think bilingual outreach is important. But unless my math is off, the redetermination under your own data is going to affect up to 430,000 residents. That's 12% of Connecticut's total population. And it is important to talk about communications. I'm not sure that the communications that we've done so far really meet the scale of the crisis. And when I talk to your community partners, and specifically hospitals and health centers, but also interested about ASOs and other folks who work with the Medicaid population, I'm hearing over and over again that they don't feel adequately engaged. And I'm also hearing the second piece, which is all the communication in the world doesn't work unless we have adequate systems in place to enroll all of the folks who are impacted. So first question is, what are we doing to fully engage all of the people up and down from non-emergency medical providers? I don't know, is VEO handing out a flyer to everyone who's taking a ride to make sure that we are not missing people? This is 12% of the state's population. This is a huge number of people. And then separately, what are we doing to ensure auto enrollment or opt-out enrollment? Because a huge percentage of these folks should be eligible for free health insurance on Covered Connecticut. Why can't we just simplify this and take this off of your shoulders by implementing an opt-out program for folks to get a silver or a gold plan without cost sharing through Covered Connecticut? Wouldn't that make this a much smaller population that we need to outreach to?
Senator Lester, thank you very much for that question. Tammy, can you talk about the partnerships we have across the state with the community-based organizations? And also, I'm going to Susan Rich by our general counsel to talk about the direct to consumer, the direct enrollment, what we are doing to prepare for to do that going forward, and also some of the limitations that may limit our ability to do it as well. But we are working through them. Go ahead, Tammy.
Yes. My response is, I mentioned earlier that we work with over 1,800 community partners, right? We provide trainings to them. We have newsletters out to them. We do on-site visits. A lot of those community partners are trained to enroll folks as well. So there's a lot of ways that we interact with them from the outreach perspective. As far as the hospitals and health systems go, it gets a little bit more complicated. So when we interact with one department, sometimes that information doesn't get to the other departments or to the higher ups even. So we offer our certified application counselor training program, where we can go in, get those employees trained to be able to enroll folks as they come in, meeting the consumers where they are. A lot of times we don't get a response because, of course, these employees have their full-time jobs. So they're not always able to take on the role of a CAC and enroll folks as well. But we do offer those trainings to community partners, hospitals. We actually expanded our Navigator program. Our Navigator program is we give grants to specific community partners to help us do outreach and also enrollments. So we are interacting with them on multiple levels. So it's not just marketing and weekly and biweekly newsletters. We're visiting them. We're giving them information to pass out, right? So we're making site visits. We're giving them all of our flyers. We're educating them through monthly and quarterly meetings. And then yearly, our certified application counselors are going through a yearly training, right, to recertify. So we're interacting with them on multiple levels consistently throughout the year.
So just following up on that, because I heard this as recently as this morning from one health center that has 10 certified application counselors.
Mm-hmm.
They still have to go through Access Health to enroll people. Why aren't we leveraging them to directly redetermine and enroll folks with coverage, to take that weight off of Access Health and speed outreach to this 430,000 person.
They can enroll. So if they have a consumer come to them, they can enroll that consumer on the spot.
Okay, that's not what they're telling me, but making sure that they know that and they have the ability to tackle it seems like that could leverage.
That's why they go through a yearly training so that they're actually able to meet those consumers at their organizations and get them enrolled. So they go through an extensive training every year to be able to do that.
And what's the number? We're talking about 430,000. That's a huge number.
Sure.
I understand that this is being broken up into tranches. What is the number that we're specifically projecting will get notified by March 31st?
Senator Lesser, very quickly, last time I looked, well, we had about 100, a little bit under 100, about 429,000. And we're going to spread that out over a 12-month period. So that would be roughly about 30,000 a month on average. Some months may be higher, some may be lower. This is where the communication is going to have to be very careful, so that everyone do not believe that that somehow they're all going to lose their coverage on March 31st or April 1st.
So, but 30,000 people will get a letter on March 31st?
On average, yes. Some months are higher, some months are lower, but on average, actually not on March 31st, it'll start before March 31st to notify them that they have to come in and re-enter their information so that they could be redetermined if they qualify for Medicaid.
But the first, I think we're really focused on the first few months because we may have time to, adjust things down the road. But that first month, is that going to be? Is it? It's going to be 30,000 people or more or less? And do we know what that population is going to be? It's not going to be a random sample. Is it going to be a specific population?
Oh yeah, it would be. We operate on the first in, first out. So the first group that was extended for Medicaid, they're going to be the first group to go through the redetermining process.
And I don't mean to badger anyone, but I just want to emphasize the question I asked before and see if I could get a response. Is there anything preventing Access Health from working with DSS to implement an opt-out provision for folks who are not income eligible for Medicaid, but who have an AGI that qualifies them for Covered Connecticut? Can we create an opt-out system for them, if they don't go through all the steps? Because there are some issues with your enrollment process. There is a limit to the size of your call center. Is there a way for us to implement an opt-out system so that folks don't see a gap of coverage if they don't respond in enough time?
Sure. Susan, can you speak to that, Susan?
Sure. And hello, everybody today. And I just want to point out that the Department of Social Services has a very full, robust presentation that's coming later on in this deck on the Medicaid unwind. Right now, we were starting just with the information on Covered Connecticut. So just so you know, Morgan has a full presentation for you on that. But we are looking at that possibility of, auto enrollment. There are definitely, challenges enrolling in a QHP through the exchange with the tax credit if they were in Covered Connecticut, or even if they were above Covered Connecticut, also has big potential tax ramifications to consumers. If someone's always been in Medicaid, there's no tax ramifications. So we are looking at that and seeing what we think, is the right thing for consumers, because we don't want to put someone in a spot where they've gotten a tax credit that maybe they're not eligible for, and they played no, role in that, where they normally would as they enroll through our system, and the system explains things to them and has several disclaimers that talks about the fact that you could, if your income changes, you could owe money back to the IRS. So we're also very mindful of that, Senator Lesser. So we're just trying to balance all of that. And obviously everybody's goal here is to make sure that people don't have a gap in coverage, and we can get as many people either re-enrolled in Medicaid, transitional medical assistance, Covered Connecticut, or a qualified health plan, wherever they fall. And we're just trying to balance all of those interests.
Okay, I would just say, I hear those concerns, and obviously if somebody sees a major gap, a change in income, that could be an issue. I think you could address those with an opt-out program, and making sure that you're communicating directly with the consumer, about their choices and giving them an opportunity to get out. But it seems to me that an opt-out is the way to make sure that we're protecting the vast majority of people, and also advising them of potential implications if they choose not to enroll in a QHP in covered Connecticut.
Yeah, Senator Lesser, that's exactly what we are exploring, that we are looking at right now.
Okay. Do you have? I'm sorry. I really want to turn it over to other members, and I'm sure there are a lot of questions. Do you? This is starting on March 31st, so we don't have a ton of time. Do you know when you'll have an answer for us about whether or not that's feasible?
Yeah, I think maybe feasible, but I don't have a timeline for you right now. I really don't. But we're exploring that right now, and the updating our system to do the opt-out, that would be the biggest challenging from a time perspective.
Okay.
That's
Well,
the
maybe we need to be
challenge.
holding a bunch of these hearings then, but really appreciate that. Thank you.
Okay.
Thank you, Representative Nuccio, and then we will continue on with the slides.
We're like 3 years in, you think I'd be able to find my unmute button by now, but I think I just want to follow up, because I think we may have just touched on what I was looking at. With the 430,000 people on the redetermination, as Senator Lesser asked, I'm really wondering if there's a way to have an auto enroll and then follow up to how we could ensure, because you're right, with most of these plans, they have the HSA option, but does Covered Connecticut have an option that isn't linked to an HSA that we could do an auto enroll that's a base level plan, and then give people the option to scale up or get out of the plan should they need to before the end of the year?
Susan, can you respond?
That is what we were just talking about with Senator Lesser. That is what we're looking at. We have only one, each carrier may offer one, but we don't have very many HSA plans. Actually, most of our plans are not HSA plans. That's only at the bronze level. And Covered Connecticut is tied to the silver level plan, so that is not HSA at all. But one thing I also want to say, as James has been talking about, and myself as well, that we do want to make sure that we communicate as much information as possible to consumers in this instance, is also that Connecticut does have insurance regulations that say that only a licensed agent or producer can advise on plan selection. And we have, 3 carriers. So we have 3 different silver plans, different plans offered by each of the carriers at each of the tiers. So that's also something that we're looking at in this process as well.
How far along are you? Do you have to have that process decided by the 12 months? Like, you have to have that process decided by the end of the year. So when you actually start recertifying people, you have it all lined up. So do you feel like you've got the people in place and the time in order to be able to do something like this?
Yes. And as James mentioned, we're looking at it obviously as the unwind starts in April. We would be looking at that for the April time, not, we're not talking about the end of the year. But obviously we have to figure out, what we think is best for consumers, what we can do legally, and then also what we can implement, as James mentioned, in our system, because we will have to make changes in the system. But we're looking to do that. If we feel that we can do this and this is the way to go, we would obviously do everything we can to do it as quickly as possible.
Okay, thank you very much.
Representative Metzger, can we hold your questions until we have a lot to get to, and can we move on, or is this specifically on this slide?
It's specifically on this issue. Okay.
Okay.
So what I would hope as a member of the insurance committee is to get the timeline and the targets on enrollment. And I think I would expect and want updates on a monthly basis when we're starting this marketing effort and outreach. We need to know that we are moving in the right direction and getting enough of the re-enrollment or recertification of all these individuals. So we can't let it drag on. We need to identify if we're having problems in outreach. So I think a structural targeted plan with targeted goals on a monthly basis starting April or May to figure out where we're headed, so that we're not facing a cliff in December that's unresolvable. I don't know how you feel about that, Madam Chair. That would be my suggestion.
I think it sounds great.
Very quickly, Madam Chair. Yeah, we will have targets for each month, and in terms of re-enrollment, and we will track that, and we will be able to report back our board as well as this group as to how many people have re-enrolled in Medicaid or Access Health QHP or Cover Connecticut. That we could do on a monthly basis.
Okay, because we'll have to convene either the hospital groups or other agencies that could help us in the enrollment if we end up with a problem. That's all. But
okay.
I just don't want. I think you've heard from Senator Leslie. You've heard from the chair of the committee. Heard from Tammy. We just want to make sure that we're in front of this problem and don't get behind it. Okay, thank you.
I just want to reemphasize for the group, we have been planning for this for over 12 months with DSS, with OHS, and our community partners. 12 months we've been planning for this because the federal government kept on extending the end of Medicaid unwinding. Every 3 months they would extend it. So now because of that, we have been planning the outreach, our system updates, as well as operational. Our call center we'll hire additional staff. We will have brokers on site. So this plan has been out there for, I think we're well ahead of this because we've been waiting for the feds to end it, and now that we know they're ending it, now it's just a matter of executing and adjusting as we move forward. As many of you have indicated, if what we have scheduled or plan to do is not working because we're going to be tracking it on a daily, weekly, monthly basis, we would adjust accordingly.
Okay, thank you.
All right, please continue with the presentation, and I think we will move it along and open it up to questions at the end. Thank you.
That works. Thank you, Rep. Wood. We're going to move on to a new topic, exchange plans and potential new carriers. And so I will go ahead and turn it back over to Director of Legal and Plan Management, Susan Richby.
Thank you, Caroline, and thank you, everybody. Just give you some high-level information on our plans. We've been talking about exchange plans a little bit. We have 2 marketplaces, individual, which is the lion's share of where our enrollees are. And also we have what we call a SHOP, which is the Small Employer Health Options Program. So we shortcut it to SHOP, and this is for small employers in the state up to 50 employees. And that is a smaller marketplace for us, but also one of our marketplaces. So for 2023, Access Health sets for each year, Access Health sets the requirements for carriers for the plans and participating in the marketplace. And for 2023, carriers were required to offer the 4 standard plans that the board approves in the individual market, and also permitted to offer up to 9 non-standard plans spread around the different metal tiers. And in the SHOP marketplace, carriers were required to offer 5 plans. We do not require or have standard plans in the SHOP at this time, but we have a mix of 5 plans that we require them to offer. And then we also permit them to offer up to 15 more optional plans. So based on these requirements, the carriers decided to offer 25 plans altogether in the individual market amongst the 3 carriers, which is Connecticut Benefits, Inc., Connecticut Insurance Company, Inc., and Anthem. And then 10 plans are offered in the shop. Each carrier is offering the 5 required plans in the shop. So if you go to the next slide, please, Caroline. Thank you. An important thing that I want to just take a moment to go over with all of you is the value of our standard plans and also first dollar coverage. So Access Health designs standard plans so that we have a set cost sharing across each carrier so that consumers have an easier shopping experience. It's apples to apples. The cost sharing is the same from one standard plan with one carrier to another carrier, and the differences would be based on price, the premium that the carrier is charging, the plan network, and there may be differences in the prescription drug formularies at the different tiers. But we feel that standard plans really do provide consumers with very good value. So we also have a focus in the standard plans about what we call first dollar coverage, making sure that a consumer can access coverage right away and not have to worry about the deductible. People look at plans today and look at deductibles and think, oh, I can't access any coverage until I hit that high deductible. That is not true. All of our standard plans cover preventative services. All of our plans actually cover preventative services with no cost sharing. That is one of the tenets of the ACA this time. And also, all of our standard plans, except the Bronze HSA, which is a high deductible health plan and has different IRS requirements, all of the other standard plans include many services before the deductible with only a copay. And these are services that consumers use the most: visiting primary care providers, specialists, mental health and substance abuse disorder office visits, labs in all of the standard plans, except the gold, because there was an AV issue with that one. But in all of the other standard plans, labs are accessible with just a copay. You don't have to worry about the deductible. And also, really importantly, James mentioned, people going to the pharmacy, tier 1 generic drugs, which a lot of people use, those are also covered without having to worry about the deductible. Another important feature is that the standard silver plans, and that is the plan that is in Covered Connecticut, and a lot of our consumers are enrolled in the silver plans, also have a separate prescription deductible, and that is a low deductible. The plan deductible could be $9,000. The prescription drug deductible is $250 for the standard silver plan, and it gets even lower in the cost sharing reduction tiers, all the way down to 0 actually in the richest cost sharing reduction tier, the 94% AV tier. So that really makes these medications that James mentioned that are so important to consumers accessible as well. So I will pause if anyone has questions, or I will turn it over to my colleague, John Carbone, to talk about new carriers.
All right, since we don't have any questions, oh, wait. Sorry about that, Senator.
Yeah, Madam Chair, and Madam Chair, you organize this meeting, and I will do whatever you suggest here. But with redetermination looming and some specific questions about Covered Connecticut, I always love to have a conversation with Access Health about the full panoply of their services. But that seems to be the issue at the moment, and maybe we could encourage them and DSS to sort of focus on that question and this sort of looming crisis, and have a subsequent conversation about the full range of Covered Connecticut of Access Health's activities at some other point. Is that appropriate? If not, I'll stand down.
That sounds perfect, Senator. If we could just focus on the Covered Connecticut redetermination slides, and we will have a subsequent informational session. Thank you.
So, Madam Chair, very quickly, so we're going to focus the rest of the meeting on our strategy and plan for redetermination for the 430,000 Connecticut residents who are currently on Medicaid extension unwinding. Yeah, that's excellent, because we have a very detailed. DSS is going to kick off the presentation discussion about the strategy plan for to ensure minimize the risk of anyone having a gap in coverage as a result of the Medicare extension unwinding. DSS.
Thank you, James, and good morning, everyone, again. So I think at this point, we're all aware of what the PHE unwinding means. The flexibilities that were enacted during the COVID-19 public health emergency now have a scheduled end date as far as the Medicaid continuous enrollment provision ending. If you can go to the next slide, please. So this is the newest change that we have with the Consolidated Appropriations Act. The Medicaid continuous coverage requirement from the Families First Coronavirus Response Act is no longer tied to the end date of the public health emergency, and the continuous enrollment requirements will end March 31st, regardless of the PHE declaration. So beginning April 1st, states can terminate Medicaid enrollment for individuals no longer eligible, and we have up to 12 months to initiate and 14 months to complete the renewals for all individuals currently enrolled in Medicaid and CHIP. Next slide, please. So here is a picture, a visual of the unwinding timeline that Connecticut is following. There were a couple options for states, and we chose this called option B. We are going to begin initiating the unwinding related renewals in March, and the first set of these renewals will be due in April. And as James mentioned earlier, we're using the full amount of these 12 months to distribute and even out our renewal plan throughout the year. So each month we'll have a portion of the members extended under the public health emergency extension that'll be due for renewal and given the opportunity to re-enroll or enroll in new coverage. Next slide, please. So I wanted to share for Husky specifically, what renewals look like from a system perspective. So approximately 60 days prior to a renewal due date, the renewal is initiated and the system attempts a passive renewal, which means using available data sources so that we can confirm the self-attested information that we have on file. So if there are successful matches, we do what's called a passive renewal. And if there's a mismatch with the data sources, the passive renewal is failed and a manual renewal needs to be completed. So approximately 45 days prior to the renewal due date, notices are generated for successful passive renewals, informing clients of their updated coverage and option to update information if it has changed, but there is no action required by the client. And then a pre-filled renewal will go out for households that failed this passive renewal process. Client intervention is required to complete their renewal, and they can do that online via the phone or paper renewal. Next slide, please. So here is what a passive renewal looks like from a client's perspective. They get a version of this notice, and it details that it's time to renew their coverage. It shows them what their current coverage is. And if the passive renewal was successful, it tells them that we tried to renew their coverage without asking them for more information. We did that, and their new enrollment is shown below that. It tells them that they don't have to report any changes, and they'll automatically be renewed. It also includes a pre-filled renewal form. If they have any changes to report, if any of their information is different, it's very easy for them to highlight what is different and either return that by mail or call into the Access Health call center or go online to the customer portal to report any changes. And then if they do have changes from what we previously had on file, they can go ahead and come in whatever format they decide to have their new enrollment determined immediately. Next slide, please. So if they failed passive renewal and a manual renewal is required, the notice is similar. However, it details the fact that we tried to do a passive renewal without asking for more information, but we were unable to. And then it gives them a date in which they have to reply in order to renew their coverage. And that date is the middle of the month, in the month in which that renewal is due. And it encourages them to provide that information early so that there's no gap in coverage. And it emphasizes the fact that going online or calling in is the fastest way to get redetermined. Next slide, please. So what are we doing now? And what we have been doing is this Update Us So We Can Update You campaign to connect the community with DSS. As you know, there's multiple types of Medicaid coverage. There's other programs that are the population that's on Medicaid may have. And sometimes it's a little confusing as to where they go to contact us. And this also during this unwinding process, some of these members we haven't had contact with in 3 years because their coverage has just been being extended. So we followed CMS guidance and really have put some emphasis over the last 8 months to really have people come in and update their contact information so that we can ensure that they're getting these updated notices and are kept up to date. So we have a new website and a media campaign with this Update Us So We Can Update You. Next slide, please. So we've launched this in several different forms of media. Here's an example of what's being updated in inner city news. And it's important we targeted areas to get the most bang for our buck in this media campaign with a higher concentration of Husky or Medicaid enrollees. So that would be the Hartford area, the Waterbury area, and the Bridgeport area. So these are also available in both English and Spanish and targeted to the inner city news and the most popular Spanish reader subscribed newspaper. Next slide, please. So hopefully you may have seen some of these around. Similarly, we targeted high volume Medicaid enrollee areas with both English and Spanish out-of-home posters. So these are the smaller billboards that you see in your community, and they're encouraging people that are on any of our programs to make sure their contact information is up to date so that they can get any important news. Now, the reason this is so focused on updating your contact information is we want to walk that fine line and not cause any panic, like what's happening, what's changing, I need to call right away, I need to go online. We just want to focus on, hey, have you moved? Is there any update in your contact information that you can provide? Next slide, please. So here's another example, same billboard style, same messaging. It's on in the same geographical areas, English and Spanish on buses. Next slide, please. So we also have done a soft launch on what we're calling our PHE Unwinding Toolkit. Next slide, please. So here's a preview, and we actually just updated this today with some of the language and messaging changes with the new Consolidations Appropriation Act. So here you have the homepage of our PHE Unwinding website, and with the message, keep your benefits active. We don't want it to be scary or alarming. We just want people to know there's some things that you can do because things might be changing. How can you keep your benefits active? Next slide, please. So what we have here is a beneficiary toolkit, what we're calling it. So this part of the site has information for benefit recipients, SNAP, Medicaid, cash, frequently asked questions, documents. So as the news starts to spread about any changes happening during this unwinding, there's a central source that they can go to find answers to their frequently asked questions. And there's a direct link for them to the Update Us So We Can Update You website if they need to update their contact information. Next slide, please. So similarly, we have a toolkit for our benefit partners. So think ASOs, community healthcare centers, End Hunger CT, everyone that we work with in the community. And James spoke to this earlier about how we're really trying to leverage their connection in the community. So what we've created for them is a toolkit, pre-prepared content that they can take and put up on their social media platforms, their direct to consumer emails, automated phone calls, and frequently asked questions, anything that we can help provide them so that the messaging is the same across the board. Next slide, please. And this is something Access Health put together to reiterate our unwinding plan. Representative Wood, Madam Chair, would you like me to pause here for any questions on my previous slides?
Sure, because I was going to ask you a question. I'll take that opportunity. How many people have clicked on that website from those billboards and bus ads?
So I don't have statistics today. We just started the media campaign in end of November, early December, but I will take this back to my team and get you guys an updated number. We are limited in how well we can track some of this information, but what I can tell you is that we have had reports of an increase in both calls to the Access Health call center with questions, and they have a very great knowledge base where they have articles and they are able to track the searches and if people are reading those articles. And there has been an increase, a small increase in questions about updating your contact information, and then a larger increase in questions about renewals.
That slide is passed, but I believe that I didn't see a number on there. I thought it was just a website. Yeah, if you wouldn't mind just going back to that. And then does 211, if people called 211 and ask about this, are they prepared with answers?
Yeah, so I'm actually meeting with the ASOs and some of the community partners tomorrow and making sure that they're aware of that this information is available to them. And I met with CHNCT yesterday, and they had some really great feedback on what else we can provide to them so that they feel more prepared. So, and one of those things is making sure that they have the same messaging that we're providing so that they can tell the members the same thing. And currently, especially CHNCT has been doing a communication campaign of their own. And monthly, what they're doing is they're sending out automated emails with this pre-prepared messaging that we've given them. And if the emails are not opened or unsuccessfully delivered, they're following up with an automated call. And we know that they are actually able to track their success rates of both the emails and the successful calls. And they've been sharing that data with us throughout this campaign.
Okay, I'm sure we'd love to see that. Thank you. I will go to Representative Gilchrist, followed by Senator Lesser.
Great. Thank you, Madam Chair. And thank you so much to the department for all the work on this. My question has to do with the slide you showed about the form folks will receive if they need to submit information back.
Sure.
Thank you for bringing it up. So for example, you have until June 15th. When will they have gotten this form in the mail?
So this one will go out middle of the month before. So approximately 45 days before their renewal is due.
Okay. And then, okay. And not, okay. I'm just worried people won't, I mean, there's only so much we can do, but that people won't.
Sure. And I just want to reiterate, we all have the same concerns. These are our, fellow Connecticut residents. We really want to avoid any gap in coverage, and we are working very diligently. And as James mentioned, we've started this and planning for it practically a year ago, because when it was tied to the end of the PHE, we didn't know when we were going to have to start. We had to be ready to press play, so to speak, at any time. We might have only had 60 days notice to do so because we were waiting for announcements of whether or not the PHE ends. So the CAA has given us an opportunity that now we have a date and we know that we're driving to. And all of the work we've done in the past year has gotten us prepared. There was a slight shift in the language in our messaging because of that bill. And now we've made updates to our content. It's gone live on the website. So we can just pivot just a little bit so the language isn't tied to the end of a public health emergency.
Is there any way to have June 16th, I'm just using these dates, June, for this example, 16th, 17th, or 18th, like to be able to see who submitted their data, who has not, and to send another follow-up, like a postcard or a phone call? Is there no capacity for that?
No, there absolutely is. So what we will be doing is for the population so now, mind you, as you know, during this whole unwinding, there is going to be the regular renewals, people who have maintained renewal come in during the PHE and are in their regular cycle. So that's going on. The notices that they'll be getting are the same. So if a client's done a renewal before, they'll be familiar with the process, but we are also doing direct standalone messaging to those individuals that have been on extension and may not have completed a renewal in as many as 3 years. So what we'll be doing is, after the passive renewals are successful, the individuals that are getting these manual renewal notices will receive a standalone notice reminding them that they've been on this extension, that things have changed, and it's very important that they renew their coverage. And that's going to happen on a month-to-month basis. And another notice does go out if they fail to provide their renewal information or complete their renewal. A warning notice goes out to remind them that they do really need to come in and complete the renewal before the end of the month, or risk a gap in their coverage. And that's something that we've always had in place, but we are doing additional messaging specifically for this extension population.
Fantastic. Thank you so much.
You're welcome.
So Representative, as you might imagine, a lot of people have moved around over the last 2-3 years. So some of this population may not get the notice. And we know that from history that happens. So if they didn't come in to update their information in our system would send the notice to the last known address. So one of our, this is why the presence in the community, working with our community partners are critical. So we capture as many of those folks who have moved and who have not received the notice because they went to the previous address. So, so working with our community partners on a regular basis to get the information out and be there, so that when that population shows up for other services to get help, we'll be there to inform them, to inform them that their Medicaid may have ended, and that they need to reapply to continue to avoid a gap in coverage. And also our community partners as well are very aggressive in communicating, doing outreach, using the information that DSS just spoke about, as well as our own toolkit as well. And again, our toolkits and DSS's toolkit are in sync with each other.
Great.
I hope that was helpful. You're welcome.
Yeah, very. Thank you.
Yes, thank you, Madam Chair. And first, I was very encouraged to hear about the outreach that you're doing. You said you're meeting with ASOs, I think, today, and that's very encouraging. I am still hearing from community partners that they don't, including providers, that they don't feel like they are doing everything they can to support DSS and Access Health in this. So I would love to know if there are steps we can do to make sure that we have, regular meetings with all of the stakeholders, from nursing homes to health centers to hospitals to ASOs, to just make sure that it's all it's all hands on deck, and we're all caught in the alert, and the carriers, to see what we can do to make sure that we don't have that we're not missing things because there's not adequate communication and partnership on this. Is there more that we can be doing?
So we are doing some more. We just had a slight delay. So I hear from our community partners as well that they don't feel prepared right now. And we 1000% hear them. That subtle shift we had to do in language, we had all of this content prepared, and it talked a little bit about the PHE ending. So now we've had to make that slight shift in our messaging. So all of our content has been revamped a little bit. And that's why the meeting with the ASOs is happening this week. We will be sending, someone on my team has an extensive list of community partners that they work with throughout all of our programs. And yesterday we had a message sent out for SNAP. We are going to leverage those contacts to continue to send out like an email communication that details where we are in the process.
Okay, great.
Senator,
Go ahead.
So there's a very quickly, circle back to a statement that you or someone else asked us about. Earlier, DSS mentioned passive renewals. Passive renewals are basically as close as we could come to an automatic renewal. Basically, we verify the information we have in our system for you with the federal government, with the federal database. If it matches to a certain point, you will be automatically re-enrolled into Medicaid, into Husky. And so that's automatic, and we are looking to see if it's possible to do something similar for QHP as well. The only risk us with the access of doing it, and if you don't, the IRS, the federal government have maybe 2 or 3 years behind in data, and so if your income has changed, that's the only risk that we're trying to find how to get around that. As you indicated, put disclaimers on there, so we could automatically renew folks based on the data that we confirm with the federal government. Then send them a notice. If we've automatically renewed you, if the information that we have from the federal government is not accurate, please come in and update your information. But at least they would have the health insurance. We're exploring how to do that very quickly, and also but update our system is probably the most time-consuming part of the process. I hope that was helpful. Again, so we are doing a version of automatic renewals now for Medicaid folks who qualify based on the information that we're able to confirm with the federal data hub.
Yeah, I hear that. It's hard to say, give us time to figure this out when it's about to be February and we're talking about a huge population losing coverage in March. So that's why, I'm anxious to get an answer to that. I don't know if DRS is at the table. They have a lot of information about Connecticut residents' AGIs, but this seems all hands on deck. And actually that leads me to I want to have a couple other questions for DSS, if I may. One, I heard from James earlier that it was going to be first in, first out. Does that mean that DSS is not going to prioritize, certain institutional populations like Husky C patients first? Is it going to be across Husky types, or is there a specific priority for the 30,000 people we're going to in the first month? And then the second is it really just a data question? Is there a way that we can get, what's the true number of people who would be losing coverage if it's 430,000, but we got that information either from DRS or from another source through ineligibility? I don't know what DSS's projections are on that.
Okay, great question. Thank you, Senator. So we worked very hard this winter with Access Health to improve our passive renewal rate for our Husky members. So I can speak to Husky specifically. And we now have our passive renewal success rate over 65%. So when you look at that 430,000 people, it's a very scary number. And sure, that's the percent that needs to go through a renewal, but we're going to have a high success rate of people who are going to passively renew. We ran some test projections in January, and we came out around 65% success for Husky members to automatically renew. So that's amazing news. We had previously been down around 35% historically. So it's a huge, we took the opportunity, once in a lifetime opportunity that we had, followed CMS guidance and expanded our ability to passively renew. So that's a huge boon to us currently. And then to your question about distribution of renewals, CMS guidance, we are not allowed to stratify our renewals based on population or funding, or there's a whole list of things that we have to follow per CMS guidance. So as James mentioned earlier, we have like a first in, first out. So people who have been on this extension the longest, more likely to have their information change, will be the first renewed. while we're then set to even out our renewal, month-to-month renewal numbers going forward, so that we can have an even or a more even amount than we have had historically of monthly renewals. One piece that we will be doing is the MedConnect individuals, Husky C members, Husky C for the working disabled. The delinquent premium population will be prioritized in the first few months. So, and that noticing will go out, same timeline as a regular renewal. They're going to be notified. They're not going to be responsible for the delinquent premiums, but they will have their premium calculated when they do their renewal. And they will have the requisite 2 months to pay their current premiums and continue their enrollment in MedConnect. And on that note, with your concern about high-risk individuals, we are meeting regularly with, like I said, the ASOs, and we're working with them to identify the high-risk populations, medically needy, we would say, and make sure that they have direct outreach when it is time for them to do their renewal.
Okay, obviously this is going to be a huge lift for DSS, which has been strapped for staff even before the redetermination. And I know that, there are always concerns about call times and whatnot. I know that one conversation we've had in Human Services and MAPOC has been around your call center being closed on Wednesdays. What can we do with additional, can we make an ask of the administration to provide additional staff? And what would be helpful to make sure that you have the resources to handle this, that Access Health has the resources to handle this? Because I'm already hearing about an increase in wait times on Access Health line. I just want to make sure that we're able to process 30,000 additional people a month, trying to figure out whether or not they have health insurance.
So, Senator Lesser, James Michelle, very quickly, the call center vendor is with Access Health, and this call center serves both Access Health and DSS. Normally, during open enrollment, the call center staffing almost tripled to support open enrollment because we have a finite amount of time to enroll people, whereas Medicaid, we don't have that. But however, because of the end of the Medicaid extension, we are currently in negotiation with the call center to continue the elevated staff in the call center for the 12-month period to ensure that we continue to provide the same level of service for Medicaid recipients as we do for QHP throughout the year. We are in discussion with DSS for the additional costs that will be required to keep the additional staffing in the call center. I hope that was helpful. We are currently working at on the additional. We're working with our vendor to come up with the additional costs. Then we'll sit down with DSS.
You'll need even more people because open enrollment, I know it's in the fall, but right, if you're going to also be getting that $30,000 people a month, continuous cascade is going to continue through the fall, and then you're going to also have your open enrollment on top of that.
Correct, but remember, as I think was stated earlier, a good number of the 30,000 will be passive renewal. So the good number of them wouldn't have to do anything. They'll get a letter in the mail saying that, hey, you've been renewed in Husky Health. You don't have to do anything.
So if it's really if I understood, Morgan, if I understood you correctly, if it's 2/3 are able to do passive renewal, is that really only 10,000 a month that we're going to actually have to redetermine? Does that sound? I want to make sure I'm understanding.
Sure. So that it's tricky because we have projections based on January numbers, and as you know, we'll have February more people extended the end of this month, the end of February, and waiting for CMS guidance and some of the population that we're going to have to workaround for March. We did have a meeting directly with CMS this week for guidance, and last week, and there's some more informational sessions coming this week, so we can really nail down that process. So we don't have, I can't give you a solid number like X% of the 30,000 is definitely going to passively renew, but it has been, and we've almost doubled the amount of passive renewals we were able to do. Now keep in mind that the passive renewal notice still goes out with a pre-populated renewal form if they want to report changes. So we do have to account for that. And I will say that Access Health has been working diligently. I liaison with their call center, and they are working very hard to mimic some kind of numbers like the open enrollment. We're kind of like mentally preparing and staffing as if open enrollment were going to continue. And on the DSS side, as far as our benefit center, we are currently, we did some hiring in the summer and in the fall, and we have a posting for new trainees right now.
And so is there anything else that we can do to support you, that the governor's office or OPM could do to support you as we, on a temporary basis as we work to hobble our way through this?
Sure. So I will take that very generous offer of yours back to my team, and we'll convene and get back to you guys if that's all right.
So the conversations that we've been having with DSS about preparation for the Medicare unwinding has included OPM, AccessHealth, DSS, in some cases OHS as well. And again, we don't just talk about the call center, but we talk about everything that we have to do with respect to outreach and marketing. So we started having those meetings many months ago, and we have a pretty detailed strategy on what we're going to be doing. Again, I think we have some slides coming up talking specifically about those. And again, the associated costs for the marketing and the outreach as well. And DSS and OPM is fully aware of them because we have been talking about them. So I'm pretty sure if additional resources are needed, hopefully they would reach out to the governor's office or chairs like yourself and Representative Woods.
Thank you.
Okay, great. Let's continue. Thank you.
All right, thanks for your attention, folks. Again, my name is Caroline Lee Ruette, the Director of Marketing here at AccessHealthCT. So ultimately, we wanted to continue the conversation a bit about Medicaid unwinding because this is something that we're working hand in hand with DSS on. We will not be, as Morgan mentioned, and DSS will not be redetermining all enrollees at once. The transaction will occur over the course of 12 months, and extended households will have their coverage redetermined on that first in, first out basis. We just covered that extensively. So breaking that down a little bit more, many households could lose their Medicaid coverage. However, some extended Medicaid enrollees will still be eligible for Medicaid. So that's an important point that we just wanted to point out, right?
No, being blocked by the cameras, you can still patch the audio. You just have to patch.
Sorry, just muted that person. I just wanted to mention that, not everybody will go on to QHP of that slightly over 400,000 right audience. Some will go back into Husky. Those in Husky A who are redetermined, no longer eligible for Medicaid, may receive transitional medical assistance. So that's another service that's available to some of these folks during this time. In terms of AccessHealthCT and our estimates, we estimate that 10 to 15% of these customers being redetermined may qualify for a qualified health plan through the exchange. And that does include the Covered Connecticut program if they meet the eligibility requirements. And this is based on our historical data and what we've typically seen, right, when redeterminations are typically happening. Those just paused for the last 3 years. So we just wanted to provide some of those projections. I think that was a question that was a little bit earlier on, looking for some targets, and that is what we expect to see. And I'll go ahead and advance the slide. And we're going to talk a little bit more about some of the outreach and personal assistance that we're going to provide. Again, another hot topic in this conversation. So I'm going to transition the conversation over to my colleague, Tammy Hendricks, Director of Health Equity and Outreach. Tammy.
Hi there. Sorry about that. Hard time getting off of mute. Tammy Hendricks, Director of Health Equity and Outreach. So we do a combination of things in regards to in-person enrollments on top of our help from obviously the call center. We have our community partners who many organizations have CACs. So those are certified application counselors, and they go through an extensive training program through Access Health to be able to enroll consumers where they are. So right now, I believe we have around 100, almost 130 CACs throughout the state, different community partners. But we also have a newly extended Navigator program, and the Navigator program includes CHC, Connecticut, Greater Bridgeport Prevention Program, CRT in Hartford, and New Opportunities. And they have over 7 locations that all have CACs, but they also extend, they also help us with outreach, right, to those communities. So folks can go in all year round, they do enrollments there, and they also offer their own services as well to consumers. So we are working hand in hand with them. Of course, I mentioned Community Health Center. They're one of our navigators. We're looking to expand that during the PHE Unwind, maybe having brokers there, maybe having some folks, extra folks located at those organizations to be able to enroll people as they walk in. All right, so obviously we'll continue to do education for consumers as well as our community partners. Right now we have monthly, as James mentioned, we've been planning for this for over a year. So starting last year, we weren't only having conversations about Covered Connecticut, we were also talking about the PHE Unwind and getting our community partners ready for that. But we have a variety of different educational seminars. So we have quarterly meetings set up to train our CACs, our community partners, giving them updates as needed, letting them know where they can find resources. We're also providing them with resources such as flyers, pamphlets, whatever they need to then do outreach as well. We also have monthly calls set up for consumers. We call them healthy chats. They're general presentations that we give updates about what Access Health offers, what kind of plans, and just general information for consumers. But we've also added in information about the public health emergency and how they can prepare for that, getting their information updated, as Morgan mentioned earlier with the Update Your Info campaign. And so right now, going into the PHE Unwind, we'll continue to do all the things we typically do on a daily basis, but it'll be expanded to reach more people. So we're looking to, since as of last year, we have been tracking the PHE Unwind users. We know what areas have the most users, and so we have been concentrating on those areas with outreach events, trainings. We're doing site visits to community partners. So we'll continue to do that moving into the unwinding period. And also setting up additional community enrollment fairs in specific communities that need them. We know that some folks, this is the first time they're going through the redetermination process. So having that hands-on help in person is always great. Can you go back to the next slide? Any questions before I leave?
So, Madam Chair, this concludes our discussion about our plan. Again, this is high-level strategy. There's a lot going on under each of those bullets. A lot that we're doing. Now we are ready to answer any questions and provide any more details to clarify any concerns or questions that anyone has. But again, we because 12 months of planning, 2 hours within 2 hours, so we just kind of give you the high level overview of what we've been planning and what we will be doing. But if there are any questions at all, we are more than happy to go into any more detail that needs to be discussed before we go anywhere else beyond make it unwinding. And again, I want to say this is a very dynamic strategy that will evolve as information become more clear to us. As as communities respond, react, then we will adjust accordingly.
Senator Lesser, is this a new hand up? Okay, looks like you can continue. Thank you.
So I thought at this point we'll give you a quick update on where we are with the end of the our most recent open enrollment. My colleague Rebecca McClure will give you a quick update on that. Rebecca.
Hi, thanks, James. Rebecca McClure, I'm the Director of Technical Operations and Analytics here for Access Health. So I just want to provide some high-level updates to everybody. This is what we spoke with the board about last week. So keep in mind, open enrollment did end, less than 10 days ago. So the numbers that are in here are based on the end of open enrollment. So obviously, any reporting or that you get any numbers since then are a little bit different. I'll try and focus on things that this group, I know we're interested in the Covered Connecticut program, but just to kind of go through everything. Our call center did handle during the open enrollment period over 200,000 calls and over 21,000 chat sessions. And we support both unsecure chat, which means no personal information is exchanged, just answering high-level questions, as well as a secure chat option where we verify the information of the consumer and can provide some more detailed answers on their particular situation. So those are all kind of together in that volume. Year over year, we have seen a decrease in the number of calls that came in during the open enrollment time. So we're looking into why that is. We have been really focusing on self-service, so folks don't have to make as many phone calls, and optimistically that is working. So you see we have 108,132 individuals enrolled in a qualified health plan at the end of open enrollment. This does include just over 15,000 individuals enrolled in a Covered Connecticut program. Just for comparison, that is quite a jump due to the expansion of the eligibility rules for Covered Connecticut that went into place July 1st of 2022. Prior to that, we had approximately 900 individuals enrolled in the Covered Connecticut program. So certainly did see quite an increase in volume with that expansion. We also, at the end of our open enrollment period, had about 8,400 folks enrolled into both a QHP plan and a standalone dental plan. This was in addition to 600-ish folks who enrolled in just a dental plan through Access Health. This year, we did have the dental program was available embedded within our existing platform. So folks had one system they could log on, they could shop for their medical and dental plan in one system. Prior to this, it was two separate systems they would have to access. So we feel that's the reason behind a significant jump in our dental enrollment this year. It nearly doubled over this time last year. So we're quite pleased with that progress as well. We also see 86% of our enrollees were eligible for financial help. So that's a great sign. We continue to make some progress there. We do focus on the percentage of folks who opt out or forego being determined eligible for either a Husky program or financial assistance paying with their QHP plan. We did see a drop in the number of individuals who chose not to be determined eligible. So we do continue to monitor that and do outreach as needed. Also, we did see, as it states here, just shy of 26,000 applications come in, new applicants determined eligible and enrolling in Medicaid during open enrollment. Next slide, please. Just some, I'm not going to read it. You guys can read this at your leisure, but there's some demographics. Our QHP medical population remains pretty similar to last year. The average age in the mid 40s. And it's worth noting, again, most of our dental population is enrolled in a medical plan. So it kind of makes sense that the percentages are fairly equivalent across both markets. We did see for our plan selection, nearly half, 45% are associated with a broker this year. That is slightly up over years past. So we are seeing slightly more folks working with a broker to determine which QHP or which policies and coverage information is correct for them. So that has increased across all counties. So we are again seeing a slight increase there. In addition, the proportion of customers that enrolled in a silver plan this year is up slightly over last year. And while we continue to see an increase in folks selecting a silver plan, we do think that the expansion of the covered CT eligibility as well as the enhanced subsidies have allowed consumers to purchase that more comprehensive coverage. So someone who may have financially chosen to select a bronze, they're able to enroll in a richer plan and purchase a silver plan. Also looking, continuing down for premiums, we did see an increase in the median gross premium, the monthly gross premium, which is before the APPC is applied, directly related to the rate increases this year. So not a surprise there, but again, due to the increased financial help available to consumers, that median monthly net premium or after APPC premium amount has remained the same year over year. Looking at our retention, our retention rate is down slightly over last year. We are looking into doing some more outreach as far as the reasons for folks who no longer are requesting coverage on the exchange. So that information is forthcoming, but again, the majority of folks that chose to not enroll for 2023, the reason selected was they indicated they no longer required coverage. So we don't have an answer right now as to why they don't require the coverage, but we are looking into that. So we'll share that information when it's available. Okay. Next slide. And this slide just has a couple details. Again, we've already talked about the extension and unwinding, so I'm not necessarily going to touch on that. But just again, a reminder for folks that in order for consumers to use their QHP coverage, they do need to make that first month's premium payment. So at this point, consumers have received their January invoices, and as of again last week, the majority, 87%, have paid that first month's premium, and they are now active to use their coverage. Carriers and Access Health will continue to reach out to those folks who haven't paid that premium to ensure and remind them of the importance of making that payment so that they can use their coverage. Finally, 1095s will be going out to consumers this week. They should start receiving them in the mail. Also, they're available for consumers through their Access Health consumer portal on the website if they want to start filing their taxes prior to receiving that 1095A form in the mail. We do have call center staff available if they have any questions or concerns with that information. Other than that, that is all the high level information we have at this time. Are there any questions or comments?
Hey, Rebecca, can you talk a little bit the 1095As?
Sure.
What's in them, how do our customers use them?
Certainly. So the 1095A form is used by the consumers to reconcile their subsidy their APTC or subsidy payments that they receive throughout the year. So they would receive that form. Anyone who is enrolled in a plan through Access Health would receive that form that indicates by, who was covered, the dates, and the premium amount, the second lowest cost of the plan, the subsidy amount they received in those months that they would then use to populate and prepare their tax forms for 2022.
So just to provide a little bit more to that, this is where your advanced premium tax credits were based on the amount of income that you reported when you applied to Access Health last year. And if your income is higher than what you reported, then some of the advanced premium tax credit may have to be paid back to the federal government. All right, and but if your income was lower, then you will get a refund. So this is one of our concerns about. Anyway, we're working through that to make sure that our customers do not have to pay anything back to the federal government. That's why we notify them on a regular basis. Come in and update your income to reflect any changes in your status.
Okay, great. Senator Lesser.
Yes, thank you, Madam Chair, and thank you for that. Just one quick thing, and just because we're getting a little far away from our earlier conversation about redetermination, in speaking with the other chairs of the committees of cognizance, we would like to get an update from you, James, and your team, as well as from DSS. And so we have scheduled a follow-up hearing on the afternoon of February 2nd, and we'd be inviting you to come and give us an update, including on auto enrollment and other issues regarding the redetermination. That is scheduled currently from 2:30 to 4:30 on February 2nd, and we would really like to have an update from DSS and from Access Health at that time. We'll be sending out information to members, just as well as formal invitations to the agencies. Just quickly though on Access Health, how many? My understanding is that generally right now, bronze plans are more expensive than other options and less generous. How many people are currently on bronze plans?
Rebecca, do you have that information available to you?
I can pull it up. I don't have it up right now,
Okay.
but I can pull it up and I can get you an answer in a minute or two. If you want to continue.
And I guess while you're doing that, has Access Health considered suspending selling bronze plans since they don't make financial sense for most, if not all, and maybe they don't make sense for anybody? Has Access Health considered suspending selling bronze plans?
Susan, can you respond to that, Susan?
Yes, Senator. No, we haven't considered suspending them. And as I mentioned earlier, there are two different types of bronze plans. There is a bronze non-HSA, which is not a high deductible health plan, and the standard bronze plan that Access Health has is up at the extended range for expanded bronze. So it's a 65 AV. So it's very close to the 70% silver. And as I mentioned, does provide a lot of services not subject to the deductible. And then the HSA plan, which has a lot of requirements because it's tied to a high deductible health plan from the IRS. There are consumers, and we can pull for you the number of people. There are people that want that type of coverage, that want to use an HSA and want that type of plan. So we do want to make it available. But as Rebecca mentioned, we have seen the enrollment in silver increase. So with the enhanced subsidies, people are choosing to buy more comprehensive coverage, which is, very good news. But for some people, that is an option that they do, want to have. But also this is why we have brokers available to really work with consumers and help explain their options, and so people can look at, and we also have a consumer decision support tool that's integrated inside of our online enrollment application. So people can put in information about their specific health needs, doctors, and that they see, prescription drugs, and get information back on the cost, what their out-of-pocket cost, might be with each type of plan.
And this may be a conversation for another day, but I keep hearing that because DSS. I keep saying DSS. I'm on Human Services, so that's my new default agency. But because Access Health tools show by default the unsubsidized premium first, it sort of directs people to less affordable options because they are unaware until they click through the full enrollment process that they may be eligible for Covered Connecticut or for advanced premium tax credits. And so that seems to be a continuous issue where people are I think unless they go through a broker perhaps paying more than they should because they're misunderstanding where affordability truly lies. And so that's going to be an ongoing conversation with you, and I don't know that we're going to resolve that this afternoon. So I just wanted to state that for the record, and maybe we can circle back in a future date.
Sure, and I will say the system does tell the consumer upfront when it starts showing them plans. It does tell them about the APTCs that they are eligible for. So they do see that, and for some people who are at or below 250% of the federal poverty level who are eligible for the cost sharing reduction plans, some of that population is Covered Connecticut, some of it is a little above that income strata, but they also see it defaults and shows them those plans first. So for people who are eligible for CSR plans, it shows them those first. And it actually, we also put in messaging in our system so that for someone who's eligible for those plans, if they try to select a bronze plan, a warning pops up and tells them that they're, warning, you might be choosing the less beneficial option for you. And also with regard to tax credits, if someone is maybe looking at shopping, maybe they're not eligible for CSRs, but they're looking at shopping down to a bronze, they also get a warning message if they're leaving some of their tax credit on the table, if you will. So we do have a lot of consumer protections in the system to really help people, know what their most affordable option is.
Okay, well, that's really good to hear. And let's keep that conversation going.
Thank you.
Thank you, Representative Gilchrist.
Great. Thank you, Madam Chair. I just want to applaud the department for what you did with dental. It seems like that was a great strategy. Pretty cumbersome to have to go in twice. So to connect those two and the results seem to be working. So thank you. Just wanted to say that.
Thank you.
And Senator Rep. Lesser, I just wanted to circle back. Right now for our bronze enrollment, we do have just about 39,000 individuals enrolled in a bronze plan. So that's about a third of the enrollment is in a bronze. So just to kind of circle back on that question from earlier.
Senator Lesser, we could look at the enrollees to give you the demographics, basically how old they are, how much money they make. Again, as Susan indicated, some of them want that option because of where they are in their lives, and they could be very, very young. Or again, they may be put money aside in an HSA account. So again, now we could look at the details of the enrollees into the bronze plans to give you a more refined picture, so that we all could assess why they chose a bronze plan for themselves.
Now, my lay understanding of where things are right now is that suggests that many of those folks might have more affordability on a silver plan given the APTCs, and that's why I'm concerned that they may have assumed incorrectly that because bronze is where we give third place folks that is more affordable than silver or gold, but that may not be the case currently. So I'm worried that people are overpaying, not realizing that there are more affordable options. And that's why my first thought was design, but also, well, either design of enrollment options, but also whether or not we really need those products currently. But
so, Senator Lesser, again, this is our first reporting of the after the end of open enrollment. Next month, we're going to have a very detailed presentation for our board, a report. That'll be on our website. We look forward to this group as well. That will analyze all of our customers' choices, and then the statement you just made. we'll be able to look at that in more detail to see whether or not if any of our customers made those choices based on that. Now, we do know people when they shop for health insurance, they look at price. They look at the premium, their monthly premium. We know that, that's the behavior of our customers. That's why we encourage them to use our consumer decision tool to make them to try to draw them away from just looking at the price of the premium. Basically, look at your health needs, and your deductible, your copay. Then that kind of puts you in the path the best plan for you and your family. But we'll have more information going forward.
Thank you, Representative Nuccio.
Thank you, Madam Chair. Sorry, I just wanted to follow up on what Senator Lesser had said and confirm with what we just heard from Access Health. I know plenty of people who have a bronze plan because that's their active choice to have that, because they don't go to the doctors often and they're not using it, and they see it more as a catastrophic plan or a plan that just covers it. So I think you said this, but I just want to confirm, do you know how many people we currently have on the bronze plans right now? Is it a large populace?
It's about a third of our enrollment is enrolled in a bronze plan.
Okay. And I don't know if this is PHI or anything like that, but is there any way to find out, is there a way to look at that populace and be able to kind of determine if there are people that we may want to counsel that they might need a different plan, or, based on some of their information that this is where they're picking because it's where they want in their life right now? I don't think we should get rid of the bronze plan, and I don't know with the ACA if we actually can. I believe there's 3 metal plans that have to be offered, the bronze, silver, and gold, but I'm not sure if the state has anything different than that.
I'll defer to Susan on the about that bronze plan piece, but I can speak a little bit. As James mentioned, we are putting together some more metrics and breaking down that population a little bit more, so we can probably next month when we share that those details out, we can certainly dig into that a little bit more and see if there's anything that pops up as a need to outreach to folks.
So, Susan, can you repeat, Susan, your statement about the soft stop we gave folks if they qualify for? Yes. Can you repeat that, please?
Yes, that we put in some warnings in the system a few years ago, so that people who have income 250% of the federal poverty level or below, who are in QHP or are eligible for what are called the cost sharing reduction plans, which provide them with lower cost sharing. The lower the income, the richer the plan. And there is a warning in there if that population tried to pick a bronze plan or a gold plan even, to warn them that they're leaving that cost sharing reduction benefit on the table if they migrate away from silver. And also just to point out, and you're correct, Representative, that there are certain requirements of minimum offerings by the carriers. And I just want to also remind everyone that there are actually 5 different levels of plans that are available. We talk a lot about bronze, silver, and gold. There are also platinum plans. For last year and this year, we've actually had a non-standard. We don't require the carriers to offer platinum because that is the richest plan. And we found in the early years there was not a great deal of interest in that tier, but there is some interest. And one of our carriers, Connecticut Insurance Company, Inc., does offer a non-standard platinum plan that some consumers do choose. So we've had that in 2022 and again in 2023. And we also do have another group of plans called catastrophic. That is, you mentioned the word colloquially. There are plans that are actually catastrophic that are slightly below bronze. Generally, with ACA rules, those are only for consumers who are under age 30, or for a consumer over age 30, they have to come to the exchange for an exemption based on affordability to be eligible. But there are some people who choose to enroll in those plans. But as I mentioned, our bronze plans, our standard bronze non-HSA plan does provide consumers with the ability to see, primary care doctors, specialists, mental health visits, those labs, and also that tier 1 generic drugs. So as James mentioned, there are some consumers who may be just younger, healthier, who don't, use the plan other than for maybe some of those types of visits. So bronze for them is, a good option at the premium price.
Now, I would say,
sorry,
no, that's
just an
okay.
Access Health is an exchange. So that is also part of the ACA, to provide consumers with these different options.
So my only last thing on that would be, is there a way, you mentioned that you have these edits when people select this plan, is there also, to kind of quell some of the concern, is there a way to have an edit on there that says, you are confirming that you are picking a plan with the highest deductible. If you were to incur medical expenses, you are expected to cover the first $3,000 of those expenses, kind of thing. Just so it's like a second point saying, oh, okay, so on top of my premium, I have to cover this. Just from an educational perspective, is there a way to put any kind of edit or information in the system to kind of make sure people are very aware of the plan that they're picking and what their financial responsibility is for those plans?
That's a very good point. And Rebecca, I don't know if you recall, and I don't, so my apologies off the top of the head, exactly the language in those warnings that pop up, but we can pull that up for you, to share that with you, exactly what the consumer sees about that. And I think it does make that point to them. I don't know if it goes as specifically as you just mentioned, but it does. And obviously, it's something, if the committee and legislators are very interested in that, it's something we could always look at, that would have to be a system change, but, adding additional language at that point as well.
Yeah, I think that's a good idea, because that's one of the things we hear from a lot of people who will pick the bronze plan because it's the least expensive and then get very upset when certain things are not covered or they have to pay out of pocket. And then we hear from legislators and people how, it's a predatory plan, et cetera, et cetera. But, I'm an informed consumer when you're putting something up that says, I'm actively picking this plan. I know that I'm going to pay less for this plan. I am responsible for the deductible and for the services that I incur that are not covered or are part of the deductible. So I'd like to see something like that if you have it, or if there's any kind of edit that we could put in there, because an informed consumer is the best consumer. So that's all I have. Thank you, Madam Chair.
Thank you. Move on. Do we have additional slides, or is that the end?
No, that's it. My apologies. No, this concludes our presentation. And
Okay,
I understand.
I'm so sorry. Please continue.
No, it says we'll prepare an updated presentation for this group on February 2nd from 2:30 to 4:30. So we'll come back, updated information, again specifically talking about our planning and strategy for the unwinding of Medicaid going forward.
Great. If you wouldn't mind, I just have a couple of questions on Access Health plans. Just to clarify the numbers that I saw on an earlier slide, there's 108,000 and change people. So that means there's an additional about 2,000 people from last year. Is that correct?
Rebecca.
Sorry, I was coming off mute. Right now, as of the end of open enrollment, we are slightly less than where we were at the end of last year's open enrollment. But if you're looking, we did go up compared to where we were just before the start of open enrollment. So it kind of depends, Representative Wood, on what number what point you're referencing. But yes, we're plus or minus about 2,000 over that point.
And just to clarify, the carriers cannot directly reach out and sign people up through Access Health, correct?
Susan, can you talk to that, Susan? You could talk about, go ahead.
Oh, sorry, James. Yes, that is correct. The enrollment all goes through our system, but there are, some people at carriers go through. We've been talking about the CAC program. We also have some people at certain carriers that are interested in providing additional assistance with enrollment. And so they've been trained to be issuer affiliated. CACs to also assist with enrollment. But all the enrollment, even that they do and the CACs do and navigators, still comes through our platform.
I'd be interested in exploring options for having the carriers be part of the enrollment process. I think we've raised something to that effect in our committee. I will just make a statement that we have subsidized plans available, and I was hoping that we'd have more people be going to the exchange to purchase plans, and I don't see that happening. So I think there's either lack of information, something happening where we are not getting the communication out to people that they could save money by looking at the plans on the exchange. So would love to chat with you guys further about that. I'm not saying that we need to have answers for that right this moment, but that's something our committee is very interested in. So would love to have you at the table. And if that's it, I don't see any other hands raised. So thank you everyone for your time, and we'll see you next week.
Thank you very much, Madam Chair.
Thank you.
Thank you.
Thank you, everyone.